Good evening, everyone. I'm Dr. Maryam Lustberg, and this is the third installation of our San Antonio Update series. Tonight, we will be talking about updates on metastatic breast cancer. Our speaker tonight is Dr. Adriana Kahn, who is an assistant professor of medicine and medical oncology. She is also has an active role in the phase 1 clinical trial program, is a therapeutic clinical trialist, and encyclopedia of knowledge on all clinical trials. So very fortunate to have her present tonight. As you think of questions, feel free to put them in the chat. And then we'll also should have time at the end for your questions. Dr. Kahn?
Hi, everyone. Thank you, Maryam, for the introduction. Good evening. I see that we have a varied audience, including people that are not medical oncologists. So feel free to ask any questions if you think something is intriguing, something you're not used to or not familiar with. I'd be happy to explain in any way I can make it easier for everybody to understand some of our updates. We have, as you all know, a big meeting called San Antonio Breast Cancer Symposium every December. And this is a huge meeting for breast cancer where we have a lot of updates on trials that change management. So we have a summary of what we've seen this past year now in December, and I wanted to bring that to you. So we're going to I distributed the studies based on their disease type. So we have trials in hormone positive patients, trials with patients with HER2 positive disease, patients with hormone positive and HER2 low or ultra low, which is a newer category of HER2 IHC, different than the standard that we are used to, and some additional newer investigational therapies that I thought was interesting to share. In the hormonal positive setting, one interesting study that we had this year was with a drug called imlunestrant, which is an oral selective estrogen receptor degrader, or an oral SERD. You may all know of fulvestrant, which is an injection that we do intramuscularly to help patients to treat their endocrine sensitive disease. It's a degrader of the estrogen receptor. And we've developed novel agents that do the same, but instead of as an injection, as an oral pill. And what these drugs do is that they go on the estrogen receptor and they attempt to destroy it instead of trying to block the amount of estrogen around, because some tumors develop endocrine independence. They start not needing that estrogen anymore to have the cancer growing. And that way, these drugs are hoping to destroy the whole receptor instead of trying to work around this. So this is one example of them. We have one that is already approved called elacestrant. This one in the AMBER-3 trial is called imlunestrant. And it's been used as monotherapy and in combination with a CDK4/6 inhibitor called abemaciclib, which is a cell cycle inhibitor that adds an efficacy to the endocrine therapy therapies. In patients with hormone positive, HER2 negative that were pre-treated with endocrine therapy. So this is the design of the study. Patients with hormone positive, HER2 negative breast cancer, they have been through adjuvant therapy, and they recurred on or within 12 months of completing their adjuvant therapy, or they were patients with advanced breast cancer that progressed on their first line of endocrine therapy with or without the CDK4/6 inhibitors, but no other therapy had been given so far for advanced breast cancers. And they were distributed, randomized into 3 groups. One group was to receive the SERD, or the imlunestrant drug alone. Another group was to receive the standard of care therapy, which is at this age fulvestrant and or exemestane, which is an aromatase inhibitor. And the other group went on to receive imlunestrant, which is the same SERD as the option number 1, or group A. But in addition to that, they also received abemaciclib, which is the CDK4/6 inhibitor. Their idea was to understand how much the oral SERD would compare with the standard of care, and also how much would the addition of the CDK4/6 inhibitor to the oral SERD would do in terms of improving progression-free survival, overall survival, response rates, and of course, keeping the eyes on safety. So patients were well distributed between the groups. The randomization worked well. most of the patients had the same amount of ESR1 mutation, which is a mutation we have in the estrogen receptor that confers this endocrine independence or estrogen independence, and it's uh, once this mutation is present, the oral SERDs actually they act better than the standard of care therapy, which is fulvestrant, based on other studies. So it would be interesting to see what these results show. That's why they stratified, and they also distributed that well between the groups. Patients with PI3 kinase mutations were also well distributed, which is another mechanism of resistance to therapy and aggressiveness of the cancer. So they could see that those patients had the same amounts of those mutations. And they were also well balanced in terms of which therapies they had received upon inclusion in the study. The primary endpoint of this study was to understand how much we could improve progression-free survival, which is the time between the patient receiving the newer therapy and having a growth of their cancer or death. So we can see that in the group that received the standard of care therapy, which was the injection of fulvestrant or the pill exemestane, which is an aromatase inhibitor, the time between the initiation of the study and progression, the average median was 3.8 months. And then just switching the therapy to the novel agent, which is imlunestrant, you could increase in a couple of months the amount of time that people were on these drugs and then having delaying slightly the time to progress. So that was something that they could see that was statistically significant, of course, and I'm sharing that with you, saying that it's significant, but we know it's not ideal. It's still a short amount of time, but little by little, we hopefully will get there. And then they showed that all subgroups pretty much favored receiving the imlunestrant. So they try to see if there would be a specific subgroup that could benefit more or less. So for example, if patients have visceral metastasis versus bone-only disease, liver involvement, or if they had received or not the prior CDK inhibitor, if they had different status on their PI3 kinase mutation pattern, or ESR1 mutation. So they could see that pretty much everybody benefited from the novel SERD or the novel oral drug compared to standard of care. They also showed here the progression-free survival difference in the novel drug with the standard of care in all patients, not necessarily. So this group here is the patients that had the SR1 mutation. So the ones that we know that the oral SERD is better. But then when they grouped everyone, not just people with that specific mutation, they could see that the benefit was not as impactful. They could see that the difference was not necessarily statistically significant. So favoring what we knew, that indeed the presence of the SRO mutation seems to favor the oral drugs a bit more. And once that mutation is not there, they act almost equivalently in terms of efficacy comparing fulvestrant and the oral SERDs. And then this other analysis is now, instead of just looking at the endocrine therapies amongst themselves, they are seeing the oral SERD, which is the pill that destroys the estrogen receptor, in combination with a CDK4/6 inhibitor in patients that most of these patients had received prior CDK4/6 inhibition. So this now shows that adding a CDK4/6 inhibitor does increase much more significantly the progression-free survival in all of these patients. So that 3 to 5 months that we saw before with just the oral endocrine therapy now has bumped to 9.4 months on therapy if you add on the CDK4/6 inhibitor, which is again consistent with prior studies, and that is why these drugs are now part of our arsenal to treat hormone-positive breast cancer, because they do lead to that large improvement of progression-free survival. And again, they try to see if they could find any specific subgroups that would benefit more particularly, and they couldn't seem to find any group alone. One group that had received prior CDK4/6 inhibitors, the addition of the abemaciclib, if they haven't received that before, was slightly less prominent in the second-line setting. But overall, everything seemed to trend towards a benefit on abemaciclib plus imlunestrant versus just the imlunestrant alone. So that shows us that that this is impactful, an impactful option, and adding on the CDK4/6 inhibitor to the SERD is important. And then now here they're trying to stratify patients by the SRO mutation, like they've done before with just the hormonal therapies. And in here, they can see that regardless of that mutation, if you're treating with a drug that seems to act as a destroyer of the estrogen receptor, adding the abemaciclib is important and improves the progression-free survival no matter what the estrogen receptor mutation status is. So again, it just reinforces how important it is to treat patients with a CDK4/6 inhibition, and opens that the imlunestrant is an option of therapy for these patients. Here they're trying to look at other subgroup assessments too. So patients with PI3 kinase mutations, patients with prior CDK4/6 inhibitors, and for all, it tends to be better adding the abemaciclib to the imlunestrant versus just doing the imlunestrant alone. They're showing here the amount of disease response, so how much patients had shrinkage in their disease. Again, I think what the take out of this study is that you do have an improvement of the amount of responses when you use the oral SERDs. But this improvement is much more marked and pronounced when you add on the CDK4/6 inhibitor. So you can see that the responses do vary from 8 to 14%, but when you add on the CDK4/6 inhibition to the oral SERD, you can see that those response rates go in the 20s to 30% range. So it's just showing again how important it is to use these drugs, and something that we can do sequentially. We don't need to just do them once, which is a trend we are seeing in newer studies showing the same results. This is showing the data on overall survival. Data is not fully mature, so it's hard to make assumptions or conclusions, but it's seeming to trend the benefit of the oral SERD versus the standard of care therapy, especially for patients with the SRO mutation in the group that is being treated with the monotherapy. In terms of safety and toxicity, overall, nothing that comes to mind in terms of a concern comparing the oral SERD that is novel, which is the imlunestrant, with the standard of care therapies. They all have a similar amount of side effects in terms of those symptoms that we know that these drugs can cause: fatigue, diarrhea, nausea, joint aches, and the discontinuation rates are overall very low. And then when you add, though, the CDK4/6 inhibitors, indeed, you can see many more adverse events, which is again expected from this class of therapy. Most of these adverse events are low grade, so grades 1 and 2. A lot of these side effects we already know and expect. So with that being said, we've been using these class of therapy drugs, CDK4/6 inhibitors, for many, many years now, and we know each of them individually. We know what to expect. We do our best to minimize toxicity by preparing patients well. So in conclusion, the imlunestrant, which is an oral SERD, as a monotherapy or in combination with abemaciclib, provides an all-oral targeted therapy option after progression on initial line of therapy. So that just opens the options for not just a drug that is now oral instead of intramuscularly, but also in combination with the abemaciclib, which is a drug that we tend to use the class like post-progression on first. We can try a second round of it, just switching the players, but keeping the classes as they are. So this just opens doors for newer options of therapy. Beyond specifically this year, San Antonio, I just wanted to bring a couple of updates that were just recently done now in January. We had two drugs that are important to mention. One is called inavolisib, which is a PI3 kinase inhibitor, and this study used this drug in combination with the CDK4/6 inhibitor palbociclib and fulvestrant, compared to just the palbociclib and fulvestrant alone as line of therapy being given to patients with the PI3 kinase mutations, the ones that have been previously treated and progressed within 12 months of adjuvant endocrine therapy. So those were not de novo patients, or those were patients that had already shown some refractory behavior. And instead of doing sequential therapy like we normally do, we normally give fulvestrant and CDK4/6 inhibitor like the placebo arm group is. And then we normally choose to do the PI3 kinase inhibition as a follow-up line. The study is asking the question is of should we just add those three drugs together instead of try to do them sequentially? And the study was positive for progression-free survival with a large difference between the two groups of 7 months versus 15 months. And then we just heard news that the full data is going to be presented later this year, but they announced that the study met overall survival benefit, which is something that hasn't happened with the classes of drugs that we are using in the same setting of PI3 kinase mutations, but when we do them sequentially, none of those studies had shown yet overall survival. So this is a great finding. Again, it opens our minds to do the targeted therapies earlier and then doing the triple combination as an option for patients. Again, the side effects are some things that we already know, expect, try our best to predict. And we do have, as Maryam mentioned, I'm in phase 1. We do have phase 1 trials now with novel drugs of all of these classes, trying to make better drugs, meaning same action but with less side effects. So hopefully the drugs as they are today are helpful and they're improving survival, but we can try to come with newer versions of them that are less toxic so that people can be on these therapies for longer without struggling with the adverse events. The second mention for this year's update is a drug called datopotamab deruxtecan, which is an antibody drug conjugate, meaning instead of just giving plain chemotherapy IV and try to go after cancer cells and destroying them, now the technology is that we use an antibody with a little chain linker connected to the chemotherapy drug and try to deliver the chemotherapy drug towards the cancer site. And even if we know that some of the drug is released before it even reaches the cancer site, we also know that from the data in the studies, it seems to be a slower release of the chemotherapy, meaning that you have more exposure to the chemotherapy and potentially less adverse events as we've been seeing with these drugs. So this is one of them, one that hasn't yet been approved so far, but studies had been done. So this is the study that assessed this drug in hormone positive, HER2 negative patients that had been treated before with chemotherapy, 1 or 2 lines of chemotherapy in the metastatic setting. They were given this ADC or antibody drug conjugate, datopotamab deruxtecan versus any chemotherapy of investigation, investigator's choice. And they noticed that the PFS was improved and that led to FDA approval. And they just recently showed that overall survival, unfortunately, didn't meet statistical significance. They do see that there is a little bit of an imbalance of people getting other antibody drug conjugates after progressing on this. And it seems like patients that had received this antibody drug conjugate in this study received less subsequent ones compared to the patients that had received chemo and then they went on to receive more of those antibody drug conjugates. So this is one of the questions of whether the overall survival was decreased. The benefit was not as much seen because they ended up getting other drugs later on that do kind of the same job. But it's still shown that it's better than chemotherapy in this setting, and that led to the FDA approval. So now we have a third antibody drug conjugate to offer the patients in the hormonal positive, HER2 negative setting. And this is just a table showing pretty much all of these studies with different antibody drug conjugates in different contexts, but showing that now we have 3 of them: trastuzumab deruxtecan, datopotamab deruxtecan, and sacituzumab govitecan. They all rhyme, and that's unfortunate because they all have the same type of chemotherapy payload, meaning that it's less likely to see a ton of benefit of one after the other. It's pretty much given same chemo, just in different shapes. So we're hoping to see more of these antibody drug conjugates coming with different classes of chemotherapy payloads so that we can have varied exposure of different types of mechanisms of action. So hopefully we are seeing a lot of ADCs coming, so hopefully we have better data coming soon. But it's encouraging to see that these are better than chemotherapy and now patients have options. It makes us a little confused in terms of how to choose their sequencing, which one comes first. There's a lot of efforts in that space too to try to do investigational studies to try to sequence them in different orders and seeing if any order is better than the other. So more data to come on that world. And then moving now to HER2 positive, we have a nice study called Patina. This is a study that was a phase 3 study done to analyze if it's efficacious and safe to add palbociclib to HER2 therapy, anti-HER2 therapy and endocrine therapy versus just the HER2 therapy and endocrine therapy alone after patients with metastatic disease receive their initial chemotherapy. So just as a context, initially when patients have HER2 positive metastatic breast cancer, they go on and receive chemotherapy with anti-HER2 agents. And then after you complete the initial amount of chemotherapy that we consider to be enough to achieve a maximum benefit, we stop the chemotherapy. And then patients go on to receive anti-HER2 therapy plus hormonal blockers if they have hormone positive disease until their disease progresses. Because we know, as we've seen recently in the prior studies, that the CDK4/6 inhibitors do improve a lot the outcomes of patients with hormone positive disease, this study was asking that question. Why shouldn't we try to give CDK4/6 inhibitors for patients that have hormone positive disease despite being HER2 positive? Can we add the palbociclib to the endocrine therapy and the HER2 therapy, and then compare that to what we've been doing standardly, which is just the trastuzumab, pertuzumab plus hormonal therapy without any additional CDK4/6 inhibitor? So they randomized patients between those two groups. Again, the randomization worked well. The groups were balanced for their baseline characteristics. And they saw a huge benefit of adding palbociclib to the anti-HER2 therapy plus hormonal therapy. So now, the time that this is by the way, a very a good study in medical oncology, speaking in terms of the months. As you saw before, we were talking about 5 months, 3 months, 9 months. In the HER2 positive disease that we have HER2 therapies, the baseline amount of time for progression is already starting at 29 months. So these patients are spending lots of months without disease progression compared to other subtypes of breast cancer. So this is one thing to mention. And then the second thing is look how much benefit the addition of the palbociclib did to this already better prognostic disease. So it went from 29 to 44 months. So this is very important. It's a class of drug that we know how to manage. We know side effects. They chose in this study specifically palbociclib, which is from the 3 CDK4/6 inhibitors we have, likely the one that is easier to manage in terms of toxicities and tolerance that patients have to the drug. So we are seeing that this data is opening doors, and hopefully this would be become standard of care if they approved, because it's clear that the benefit exists. And then they were trying to look through subgroups to see if there is any subgroup that benefits best or not. It seems like everything favors the additional CDK4/6 inhibition. And this is just showing the response rates being also higher when you add on the CDK4/6 inhibitor in terms of having tumor shrinkage. The overall survival so far has crossed the threshold, but again, we know that these patients have multiple options of therapies after they go on and progress in their initial line. And this study is also small and the data is still maturing, so we are likely to see that happening later on. But just to improve that initial time between the need to switch therapies is already something relevant, and we think that this is clinically meaningful. Side effects as expected, nothing much more surprising than we know for the class of the CDK4/6 inhibitor. So mostly we monitor for white blood counts that can come low, especially neutropenia. And patients may have a level of diarrhea, not as much with palbociclib as with other drugs in the class, and fatigue. But overall, it's a well-monitored and manageable drug. So in conclusions, this is just showing that there's a big rationale that overcoming resistance to anti-HER2 therapy with CDK4/6 inhibitors seems to be indeed a thing. And that they discussed that in the slide, saying that they think that this should be considered an option in this setting. So they believe that this is a new standard of care because of the clinically meaningful improvement. And then now moving towards a new category of HER2, you all know we classically distribute HER2 by HER2 being 0 or 1+, which is the negative HER2, and then 2+ is the equivocal, and then from that we move to FISH, and then FISH tells us if it's positive or negative, or if it's 3+, it's the classically positive HER2 status. The discovery of an antibody drug conjugate like that chemotherapy that is linked to an antibody and it has a better delivery of the drug made us ask this question of, it's a HER2 directed therapy. I know HER2 positive disease is the one that benefits the most from these therapies, but what if the patients have some amount of HER2, not necessarily zero completely, but a little bit of it? Is that enough to have the drug working well for them too? So there was a bigger study called Destiny Breast 04 that looked specifically to this population of the HER2 low, meaning patients with 1 plus or 2 plus FISH negative. And then that showed benefit. And then this study went beyond just the low population, which is 1 and 2 plus with the FISH being negative, to also creating a newer category, as you can name it, called HER2 ultra low, which is any minuscule amount of membrane staining, even if the HER2 is less than 10%, which is what we consider as zero. If there is a bit of a membrane stain, they call that ultra low, and the one that has no membrane staining at all has now been called HER2 null. Um, we have a lot of criticism and pathologist comments about whether this is even relevant, whether the tests we have are calibrated enough to measure these lower levels. And there's a lot of heterogeneity also in HER2 expression. So there's a ton of discussions on the meaning of that. But nonetheless, this study included patients with HER2 low or HER2 ultra low, meaning zero with a little bit of membrane staining, to receive TDXD, which is this drug targeting HER2, versus treatment of physician's choice, which is standard chemotherapy, pretty much. And then the results of this study showed that no matter how long people took to progress to their prior therapy, for example, if they were short progressors, like they started an endocrine therapy and soon after they progressed, or if they were a medium responder, if they were a very good responder, more than a year, no matter what, when they went on to receive either chemotherapy or the antibody drug conjugate TDXD, all of these subgroups benefited more from TDXD than from standard chemotherapy. Again, improving the progression-free survival, as you can see, almost doubling it for all of the subgroups. So 7 months went to 14 months, 6 months went to 13 months, and 4 months went to almost 13 months, depending on the amount of time that they took in their prior therapies. But just showing that indeed this drug seems to be much more active than standard chemotherapy, which is a pattern we are seeing with all these antibody drug conjugates. And then they're trying to break down the amount of response too. So the overall response rates to this drug showing that it's much higher. So the tumor shrinkage goes from 25% of the patients to 67% of the patients, for example. And it goes on and on about how much the duration of the therapy is improved with this drug and how much the benefit of the disease control is with TDXD in comparison with the treatment of physician's choice. They also went to see the progression on the subsequent therapy. So let's say they went on chemo versus the TDXD, and then after they progressed in the study, they went on something else. They are showing in this slide that in the group that received the TDXD drug, in comparison to the group that received chemo, all the therapies that they've done after, the group that had received TDXD seemed to have even longer secondary progression after they progressed on the study, meaning that they're trying to, their point is that they think that getting the drug in the beginning seems to improve even later outcomes beyond that choice of drug. And even when they go on different types of drugs, it seems like the control of the disease is beneficial if they get the TDXD at some point earlier compared to chemotherapy. And so they could see that no matter what the disease burden was too, so let's say less than 3 metastatic sites versus more than 3, can we see any specific benefit or not? And they saw again the same pattern, no matter what, the chemotherapy group did worse than the antibody drug conjugate group, including patients that had no visceral disease or bone-only disease. So they had about 120 patients that were not having visceral metastasis, which is a group of patients that we always say, let's prefer standard capecitabine, for example. They don't seem to need the IV chemotherapy, so let's transition them from endocrine therapy to chemotherapy with an oral drug first. They are showing here that even in this group, TDXD seem to be better in terms of benefit of progression-free survival. So it just favors their drug pretty much because of benefit in survival, which is indeed robust. The biggest concern about the drug is that toxicity is something that we need to monitor well. Of course, with chemotherapies, we have toxicities and those are known: hair loss, low counts, fever, infections, you name it, neuropathy. TDXD has some of those. As you can see, it's the blue drug that has adverse events are happening too. And it seems to be higher than some of the chemotherapy agents. And it does have a side effect of special interest, which is interstitial lung disease, or you see in the last line here, the educated drug-related ILD or pneumonitis. So it can cause inflammation in the lining of the lung. Some rare cases, very rare, less than 2-3% can die. The patients can die from this side effect. We've been noticing that this exists with this drug, so then we scan patients more often. We value any sort of respiratory symptom, change in saturation. So we monitor them closely because if we catch this early, we can give them steroids and things get better. So we again, as much as we use the drug and develop the drug, we are noticing how to manage, how to predict, how to treat early, and we're seeing less deaths than what we saw in the earlier trials. But nonetheless, this is a potential side effect. So that's why, although you can see all the benefit, there's still some discussion amongst physicians of whether that should be their immediate first line or should we try to do other lines that do not have this potential risk. And then again, it's a discussion with the patients regarding their impression of the data, of response rates, of beneficial improvement of their survival, knowing that there is this risk of potential toxicity. So the patient discussion and physician thought process, individualized decisions are very important. So in conclusion, the drug is effective in the HER2 positive and in the HER2 low and ultra low. So even in those ones that are technically zero, but have a little bit of membrane staining, the drug continue to show benefit. So it just opened the door for pathologists and people to now start looking in the pathology reports, looking after the HER2 ultra low, so that they can start giving the drug for these patients that have hormone positive HER2 ultra low disease. We have a clinical trial that is opening soon here at Yale, led by Dr. Lustberg and me when I was a fellow, now faculty. I'm co-leading that with her, which is a study of TDXD, this drug given to people with zero HER2, even the ones that are null, because we had some signals in other studies that show that some amount of patients can still benefit from it. And we are trying to wonder, is the HER2 even needed to begin with? What else can be needed? Are there better ways to measure HER2? And Dr. David Rim, has an assay that tests for that with a more quantitative way that is more specific for the low expression levels. So we're trying to be innovative and bring in a test that might answer this question of, now I can see who are these patients that are benefiting, because the test can really pick them up. So we shall see what our study shows, but it's just important to mention. And then in the end, I just wanted to bring some investigational therapies because some of them have some studies that were opening soon here at Yale. One is with a novel way of treating cancer. It's been studied for many decades. It's not novel at all, but it's just that more attention has been given and we've been developing these compounds better now. But this is a cancer vaccine. So they made the vaccine based on a breast cancer patient, and they try to create immune response against the breast cancer by injecting the breast cancer cell that is not active with immune boosters, basically to try to allow the body to recognize that antigen and that is not masked. For example, if our breast cancer cells have inner ways to mask themselves, now we're going to expose the body to an unmasked version of breast cancer so that the body can start recognizing it and fighting it. So they presented their earlier data on the benefit of this vaccine, showing that patients had lots of lines of therapies before, including ADCs, immune checkpoint inhibitors, CDK4/6 inhibitors, a lot of patients with visceral metastases, but they were showing some levels of responses still. So they're seeing that some of the patients, especially with HER2 positive disease, had higher rates of response with the vaccine. Triple negative, they didn't see it as much. The blue one is overall response rate, meaning real shrinkage. The orange one is clinical benefit rate, meaning disease is stable. So there's a lot of stability of disease, which is good in that setting of multiple prior lines that you see constantly patients progressing. So stable disease is not bad. But you can see that the shrinkage seems to be more intense in HER2 positive, although their data is too small. You see it's just a few 40 or so patients, and we're opening their phase 3 study, which is including all breast cancer subtypes. So we're hopeful to see some more data, more patients, more responses, and then understand who, if from all these patients, who would benefit best. And they're showing also improvement in intracranial lesions. So they're seeing some responses. So anything that goes below the dotted line shows that it's shrinkage. So they're showing some shrinkage of brain mets in patients with breast cancer that received this vaccine. So we're hopeful that this would be an option. Indeed, brain metastasis is something that happens very often in the later line setting. So anything that can help our patients would be beneficial, and we're hoping that this helps a lot of them. And then I also wanted to bring some immunotherapy drugs. So immunotherapy, as you may have heard, has revolutionized, especially like in breast cancer, the triple negative subtype, and many other cancer types, lung, renal, melanoma, bladder, you name it. In breast cancer, it seems so far the triple negative is the one that is more beneficial by it. And we have a PD-1 inhibitor and a TKI, which is a tyrosine kinase inhibitor with multiple targets that had been given in combination. And we have this drug from this company in phase 1. So that's why I decided to bring this data, just to show that when you combine these immune agents with chemotherapy, these novel immune agents with chemotherapy, we're seeing response rates in the metastatic setting of up to 70% of the patients, 75% of the patients in first line. So this is showing that the average first line response rate we have so far with standard of care therapy, even with the immunotherapy agents we have as standard, is around 40 or so percent. So 75% seems to be very promising. Again, it's small study, so it's easier to have bigger impactful data with little patients. When you have more patients, you might minimize that. But we're hopeful to see that there is more to the story than just Keytruda, for example, which is the drug we do for triple negative breast cancer as an immunotherapy agent, or pembrolizumab. So we're hoping that novel immune agents and novel combinations of immune agents come to make that response rate better and improve patient outcomes later on. So that was one option. And then this is another class of drugs. So those are bispecific antibodies. This is two antibodies connected, and they have two targets. And in general, they've been targeting immune cells with cancer-related antigens. So they try to make the tumor and the immune cell meet and try to make that immune response to the tumor better. But we also have anti-PD-L1, which is an immune target, with a VEGF target, which is the vascular endothelial growth factor, so a vascular agent. So this drug is trying to make the vasculature and the like the vasculature compromised and the immune system more activated. So there were in early settings, still an earlier study, but they're showing a gain in the triple negative population in combination with chemotherapy. So it's this drug plus taxane chemotherapy, but they're seeing the same 70 or so percent response rate. So not only novel immunotherapy agents, but also novel forms of immunotherapy, like this bispecific antibodies. So we're hopeful that this disease, triple negative breast cancer, is from all of the subtypes, is the one that has the poorest outcomes, that people progress super fast. They have high chances of recurrence, even with early stage disease. So anything that makes the triple negative breast cancer disease better for patients can live longer, has more responses to their therapy, we appreciate. And we have also bispecifics in phase 1, and we have this drug, the BNT327, is coming in the breast team. So we're going to have this available in our breast portfolio for patients to benefit from. And then the toxicities are, again, things that we expect with the VEGF agents, like bevacizumab is the one that, Avastin is the one that we had before. This is Avastin plus a boost of immunity. So you're going to see some of the side effects being immunotherapy side effects and VEGF side effects. But again, things that we are known and used to treating and monitoring and preventing, and again, acting early if we see something happening. So I just wanted to show that there's a lot of newer combinations, a lot of immune agents coming, comparing the benefit of the blue lines in the bottom are the standard of care currently, and then the things on top are the novel agents and novel immunotherapy combinations, showing that they are having longer progression-free survival and higher response rates. So just uh, a little sprinkle of hope for this disease that we for sure want to see better outcomes coming early. So I'll stop here. Appreciate your time. Thank you so much, and I'm happy to answer any questions or go back to any specific slides.
Thank you, Dr. Kahn, for your great presentation. We can take a few minutes for questions, but while we're waiting for the audience, just wanted to come back to the dilemma of sequencing the 3 approved ADCs. As you mentioned, we have 2 TROP2 ADCs currently approved, plus 1 HER2 ADC. So just kind of walk us through your thinking process and also potential emerging trials.
Yeah, so let me come back to that slide so that it helps us to visualize them together. So in the so this is all in the hormone positive, HER2 negative population. So let's forget about triple negative because this is not there. This is not that space. We have data with TDXD, which is the first one of these that resulted. And the amount of patients that had hormone positive disease in the Destiny-04 study, which is the HER2 low study, was much larger than, for example, the triple negative population. So we have a good amount of hormone positive disease patients that received at least 1 line of chemotherapy. So they were earlier in terms of 1 to 2 lines of chemotherapy. So it's an earlier timing to give the antibody drug conjugate and a lot of patients with hormone positive disease. And you can see that it doubled the progression-free survival. It improved overall survival, a robust improvement in overall response rate. So for sure, TDXD is an immediate good choice. We also saw data on Destiny Breast 06, which is the next column, now including low and ultra low. So even a population of HER2 expression that hasn't been included before. Again, showing the benefit that we saw before, 8 to 13 months, showing the improvement in response rate. So again, another study confirming the benefit of TDXD in this patient population. These 2 drugs were tested in earlier line setting, so we know that that benefit exists. So that could be a great first line choice. Then we have the TROP2 ADCs. Now we're changing the antibody target, although all of them have the same class of payload. Now we're changing the antibody target to a TROP2. We have the study now that has the more recent one, which is the datopotamab deruxtecan, which is in an earlier line setting like HER2 low, Destiny Breast 04. So you have data versus investigator's choice. You see that the benefit exists, the PFS exists. The OS didn't meet criteria for benefit in terms of statistical significance. But it's hard to compare, right? These are different studies, different amount of patients. Also, the subsequent therapies could have been different between the 2 studies, but it seems like TDXD still seem to have better results. You have benefit in survival, you have a larger gap, delta between a lower hazard ratio for PFS. So when we compare Destiny-04 with Tropion-01, it makes me feel like TDXD is still my first line choice in terms of comparing these 2 ADCs. Then we move to sacituzumab govitecan, which is another of these ADCs for TROP2. This one was studied in later lines, so it can be an unfair comparison to TDXD and to the Dato-DXd because the benefit, of course, is going to be smaller if you have more lines of therapy. It did show benefit in overall survival, and then the response rate also doubled, but it's on a later line population. So I think that the bigger question is, if you treated your patient with TDXD, which TROP2 ADC would you choose as your next option? In my mind, because the payload is deruxtecan for the TDXD, which I have chosen first, it makes me want to choose sacituzumab govitecan as the next line instead of Dato-DXd, because at least you're changing also the drug. Although the same class, it's a different drug. So you're changing the antibody, you're changing the drug, and then you can see if that could lead to better responses. And it's also being studied in later lines. So hopefully that benefit is going to be justified because you saw that it had benefit in later lines. However, none of these have been studied in sequence yet, that we have results to show, look, this is what happens. And we know that retrospectively speaking, ADC1, meaning whichever you choose first, is always going to perform better than ADC2, whichever you choose second. So in general, we see bigger PFSs in the first choice and smaller PFSs in the second choice, even when you play around and you choose the same drugs in that first or second choice. So it seems like the body may develop mechanisms of resistance, for example, to topoisomerase inhibitors. You can develop resistance mechanisms with HER2 expression or TROP2 expression. So it mostly, I'd say it might be a payload. That's my interpretation of the data so far, is that it seems to be a stronger payload resistance that dictates the second drug not being as effective as the first. But we have studies coming in this space. So we have a nice study from the TBCRC we're opening at Yale, which is asking that exact question of the name of the study is Trade DXD. So they're doing TDXD followed by Dato-DXD or Dato-DXD followed by TDXD. And they're going to see that keeping the same payload but changing the antibody, how much does that benefit us in terms of which one should come first? Is there any pattern? Are they going to do the same no matter which one you choose first? Is TDXD going to be better as we think it might be if you choose it first versus second? So we're yet to see those results, but this is a nice study that is keeping the payload as the same, just changing the antibody. So that way we can have that answer if changing the payload might make more sense, because indeed now we're seeing that keeping the same payload is not allowing you to derive much benefit thereafter.
Thank you so much for that. And I think just re-emphasizing to the audience the toxicity differences between the two TROP2 antibodies, with Dato kind of having more stomatitis and eye toxicity and more GI toxicities with SASI. So I think I think your explanation of the payload and kind of considerations in terms of sequencing outside of a trial, I completely agree with. We do have a question from the audience from Dr. Ward. You mentioned the HER2-0 study, and she's asking about the HER2-low trials that are going to be opening. So you can update her on kind of our amendment that we're looking at.
Yeah, so we have in our HER2-0 study that we are opening, we are including patients that have either HER2-0 null or HER2-0 ultra low, because if they have HER2-low disease, they are already eligible to receive TDXD per standard of care. They don't need to go on a trial. That drug is already approved in that context. We have other studies that are looking to the HER2-low population with newer ADCs. So one that we just recently closed, we participated in the phase 1 study of that in the breast team, was a HER2 eribulin ADC. So it's changing completely the payload class to a microtubule inhibitor, and they included patients with HER2-low, and they did see robust responses in the patient population that had Enhertu. So it's a criteria for inclusion in that study to have received Enhertu or TDXD, meaning come after an ADC and get a new one that changes the payload, just for us to see how that goes. And they saw a lot of responses in phase 1, even while they were dose escalating. So it's interesting to see that newer agents are coming. This study is likely opening in phase 2 soon. So we shall see later what it does. And other agents are coming too. We have also TROP2 ADCs that are also including patients with HER2-low disease in their studies to see if there might be a benefit from that in the not necessarily focusing on HER2 as the antibody, but other antibodies might also be beneficial to patients with HER2-low disease. So we have also these drugs being tested in that setting.
Great. Dr. Kahn, if you could take a look at the chat, there's a couple of good questions. One is the philosophical question of should Enhertu just be given to all? If you want to tackle that one first.
Yeah. So on that question, there was a study done in Europe called the DAISY study, and they did that. They said, let's just give Enhertu to all. And then later they analyzed the response rates based on HER2 expression by HC. They did see the pattern that we see, which is around 70% response rates if you're HER2 3 plus or 2 plus FISH positive, meaning the classic positive HER2. Then they saw mid 50 or so percent in the HER2 low population, and then they saw 30% response rate in the HER2-0 population. That brings a lot of philosophical questions, meaning, of course, the more HER2 you have, it's a HER2 targeted drug, We are seeing that the benefit is larger in that population. But why on earth would technically, right? Like that's the question. Why would a HER2 0 person respond to a HER2 ADC, knowing that in the past trastuzumab had zero response in this population, just the trastuzumab alone, it has never shown to be beneficial for HER2 0 patients, HER2 negative patients. So this changed completely the thought process of HER2s just for HER2 positive and opened that door of question. The question is, these antibody drug conjugates, they have chemo in them, so they're not just the antibody. Is the drug being the linker cleaving the payload in your bloodstream, even regardless of the HER2? Is a macrophage eating up that linker and cleaving it because they are cleavable by cathepsins and all that. So that could be a mechanism of cleavage of the payload, or you have bystander effect, meaning a HER2 cell can get the antibody, bring it into the cell, destroy the antibody drug conjugate, release the payload, but then that payload is like a little bomb, exploded that cell, but it still kind of burns the neighborhood. And you may have other cells that are not even HER2 positive, but they get damaged as well by the drug. So is it because of the bystander effect that we're seeing responses in the HER2 negative population? So this is exactly why we developed the HER2 0 protocol at Yale, and then we added a lot of correlative science on that protocol to see if we could understand better why. We're going to do Dr. Rim's assay, which is a very, very specific quantitative test that looks at minimal amounts of HER2 expression. We also have other pathologies tests. We have phosphoproteomics, meaning trying to find other measurements of HER2. We're going to look into mechanisms of resistance. We're going to look into different ways to measure HER2 to see if that could be the explanation. And if we find something novel, that could be the explanation. If we don't find something, it might just be that other like I said, independent of the target, you're just releasing chemo, and it's a good chemo. We say like it's pretty much like bleach. Chemo goes everywhere. So you're just doing an infusional mechanism of delivering chemotherapy by a slower delivery of that chemo. You don't need that target for 100% of the action. So maybe that could be the explanation. We shall see, but this is still unknown. No one really knows. ADCs, the whole mechanism of action, resistance to them, sequencing, what happens in the immune system, is there any immune activation to it, or is it just a chemotherapy? So there's a lot that is under studies because no one really know the full answer.
Great. Couple more questions, Dr. Kahn. One is a CPS score needed for some of the newer immunotherapy trials?
No, so they have been including patients that have in the phase 1 department that we have, they do triple negative breast cancer, so they haven't specifically focused on PD-L1 positive patients. And then in this study here, they also did not select by PD-1 like PD-1 expression. So they are not. They're just looking at that afterwards and trying to compare what is the difference in response based on PD-1 expression, if they have any differences or not.
Great. And then probably our last question for the night is related to patients who have ESR1 alterations, kind of sequencing of therapies, therapy choice, a SERD versus fulvestrant with abema. So your thoughts on that?
Yeah, so I think that's a great question. The drug is unfortunately not yet FDA approved, but I think that when it is, it would certainly be a choice because the main choice, I would assume, because when you have ESR1 mutation, we know that the oral SERDs are better than fulvestrant. We currently have approval for elacestrant as monotherapy. So if we progress and we have ESR1 mutation, you can give them monotherapy of elacestrant. You cannot technically give elacestrant plus a CDK4/6 inhibitor if they progressed on one already. This is not yet a standard of care practice. Some people might like try to work with insurance to approve this, but this is not yet a standard FDA approved indication. So for now, the legal option is to just do monotherapy SERD. If this study and this regimen is approved, then not only you can do a SERD, just like elacestrant, but now you can also add the CDK4/6 inhibitor legally. And we know that CDK4/6 inhibitor in first line, followed by CDK4/6 inhibitor, changing the player in the following line improves outcomes. So I would say if I have this approved, it would be my next line of choice, to do the SERD plus a CDK4/6 instead of just a monotherapy SERD. You could see how much more the benefit was of adding abemaciclib, even in patients that had received CDK4/6 inhibitors before in that study. Just not to be unfair to elacestrant, which is the drug that is currently approved, they have the active Elevate study open at Yale, which is exactly that, elacestrant in combinations. And then they're combining it with CDK4/6 and with PI3 kinase and with other agents to see if the combinations can make elacestrant be your backbone endocrine therapy of choice, and then you just add whatever else targeted therapies that you are interested based on the patient mutation profile.
Yeah, completely agree. And I think whether the FDA will approve imlunestrant as a single agent or in combination is also being debated. So we do have to stay tuned for that. The question of CDK4/6 sequencing is also an active issue, since in many of these studies, we were using a lot of prior palbociclib as first line. So then kind of sequencing into a drug like abemaciclib, how do these data are going to look when patients are now most often receiving ribociclib or abemaciclib as one of their first line CDK4/6 inhibitors. So I think the question of CDK4/6 inhibitors is also very much unanswered. We don't have a timeline for the FDA approval for the imlunestrant. That was one of the questions on the chat. And then just one really last question, which is regarding how often are HER2 levels being tested in these metastatic HER2 ADC trials, Dr.
Pathologists can tell you that they have been receiving many more requests than before. So now that we have approved indication for HER2 low, results with HER2 ultra low, a lot of patients have been doing, like doctors and patients have been seeking additional biopsies. So if you had biopsies that did not show any HER2 expression, although we always favored biopsy in the disease as the disease progresses, that wasn't necessarily something people did all the time. They still defer to liquid biopsies to try to get some mutations, but not necessarily doing physical biopsies. But given that T-DXd is a drug that has changed the outcomes in patients with HER2 low and HER2 ultra low, we're seeing that a lot of patients have been getting subsequent tissue biopsies looking for HER2 expression. And also pathologists have been asked to reread prior pathology reports, just because the difference between 0 and 1 plus can be so tenuous, that if you label it as a 1 plus, patient is eligible for the drug. If you label it as a 0, patient is not eligible. And at times pathologists look back and say, yeah, it's 11%. So it's like a very mild transition for a test, like as Dr. Rim can attest, is not developed to differentiate those very well, 0 to 1 plus, but that can just be the only thing that makes people eligible. So they're coming back not only with newer tissue biopsies, but also reviewing older tissue biopsies to see if they can be changed.
And just reminding the audience that in Destiny-04, the HER2 low status could actually be coming from primary tumor. So it's really any tissue at any time defines HER2 low status. Thank you, Dr. Kahn, for this wonderful presentation. And thank you to the audience for your great engaging questions. And we'll see you next time. Thank you so much.
Thank you.